having
This
cesarean
conference
section.
will now be recorded.
No, doctor,
So,
actually, I just delivered
mhm.
40 minutes back. Yeah.
Yes, Martha. You have delivered 40 minutes ago, and my midwife have some concerns, so she has called me urgently. Martha, are you having any pain or something now? Do you need any painkiller?
There is some pain. The midwife has,
Mm-hmm.
given me something just now for pain. But
I
the thing is, doctor, I'm feeling very tired.
Yeah, I can see, Martha, that you are feeling very tired, but don't worry, we are here to help you, Martha. Are you feeling comfortable enough to talk with me?
Yeah, sure.
Martha, is it okay if I ask you a few questions, know more about you, and then I will discuss that your further management? Is it okay
Yes,
with you?
okay. Yes, okay.
So, Martha, I can see that you have delivered 40 minutes ago.
Hmm.
And could you tell me about your that are you feeling any nausea or any vomiting right now?
No,
Any tummy pain?
some discomfort is there, doctor.
Okay, and have you felt this that there was so a lot of pain before and now pain has totally vanished? Any such feeling?
No, it's there. Discomfort
Okay.
is there. Yeah.
Okay, okay. And Martha, could you tell me more about that? Was your pregnancy all this uneventful? Any complication in this pregnancy, like any high blood pressure, any sugar levels?
No, everything was normal during the course of the pregnancy as well. Also, I went in labor very normally.
Mm-hmm.
Up till then, I was fully dilated. That's when I believe that you told me that the baby was, not
Mm-hmm.
having a good heart rate, and I had to have this procedure. Even then, I was feeling
Yeah.
fine. Just now, I'm feeling tired.
Yeah, thank you for sharing this, Martha. And could you tell me more about your last pregnancy? I can see that you have cesarean section in the last pregnancy. Is that so?
Yes, I do. That was 2 years ago because I had a baby
Mm-hmm.
by the buttocks position and I opted for a cesarean for that.
Okay. Okay. Any complication after that surgery?
No,
Okay, Martha, and have you seen your baby now?
yeah, the baby is with me. I was trying to feed
Okay.
as well, but now I'm feeling very exhausted now.
Yeah, don't worry, Martha. We will help you in the feeding and everything.
Uh-huh.
Martha, any other surgery other than this cesarean section you have before?
No, no, sir, other surgeries.
Okay. Any medical come-ups which for which you are sorry?
No,
Are you visiting your GP for any medical condition?
no, no,
Any allergy to any drug or any food or something?
no,
Okay. And Martha, any family history of concern like high blood pressure, sugar levels, or any clot formation in the family?
no.
And do you have enough support to take care of your baby at home or at here at the hospital?
Yes.
Is there someone with you?
Yeah, my husband is just stepped out, but I ha do have good support system at home.
Okay, good to know about this, Martha. And are you aware of your blood group?
O positive.
And Martha, if any need arises, do you have any reservations for the blood transfusion?
No,
Okay. And Martha, are you aware of your weight and height ratio?
it's 24.
Okay. Thank you for sharing everything, Martha, with me. Martha, why my midwife called me, why we are concerned, because we have examined you, and as you have delivered, that we have applied, you are having one cesarean section, and now you went into the labor, and we have applied the instrument to deliver the baby. Actually, there are certain concerns which have arises. That one thing is that we have found that your hemoglobin, you are very pale looking. So we are suspecting that there is your hemoglobin is low, and other than that, your blood pressure is coming low and your pulse is high. So in such conditions, there can be some possibilities whenever there is some certain difficult deliveries. Then what happens that do you want my midwife to sit with you or or
Not a
may I
problem.
call your partner to be with you? Okay. So,
He'll
Martha,
be
what
at
happens that uh, Martha, what happens that after these deliveries, there can be the possibility that either because when we delivered with you the instrument, then there was a cut which we gave down below to deliver the
okay.
baby, and also there was a tear on your vagina which we have sutured. But sometimes what happens that there can be the possibility that there is a collection of the blood inside the vagina, which we called in medical terms as hematoma. And certain times there is another possibility that if someone is having previous cesarean section and they are undergoing the normal delivery, and the instrument has been applied, then there can be possibility of the scar opening. I'm so sorry, I don't want to scare with you, but because we have these possibilities for that, I would like to have certain further investigations
Yeah.
to check that your hemoglobin level, your kidney and liver function test, and also if need arises, then I will be arrange blood products for you, and I will arrange a scan also for you to check that, and I will also inform my consultant. Am I clear so far?
Okay, at this point, you've been provided with further information. Okay.
I'm unable to see the on the screen the further information.
One second. Let me fix that now.
Yes,
Okay.
yes. So, Martha, I'm so sorry to tell you this, but we have done your examination, and also we have done an ultrasound. Ultrasound is showing that there is some collection of the blood inside your tummy, and there is a big mass that can be the collection of the blood. So because this is an emergency, so Martha, what we do in such situations that uh, I will be informing my consultant. Your management will be a multidisciplinary team of the doctors. I will inform my operation theater and the anesthesia doctor, and also the blood. So what we do in such
Okay.
situations that we have, because whenever there is a collection, then it can, why we are concerned, because this collection can increase in the size, can cause some pressure on your water bag and the water pipe. It can damage your kidneys, and it can cause the increase collection of the more blood inside your tummy, and you can collapse also. So in such situation we have to
Hmm.
in your in we have to act immediately. So what we will do that I will inform my consultant and all the team members, and we will be arranging an operation theater for you, because in such
Yeah.
situations we will do which we called as examination under anesthesia. We will be taking you, we will give you something to sleep so that we can check you from down below, and also we might do laparotomy, which we called as, we will give cut on the tummy, and we will see that why there is bleeding inside. And Martha, we will uh, try to save your womb and everything. We will try to only drain that blood. And but in certain situations, what happens if it is in best interest for you, we might remove your womb. Are you
Oh
getting
my
my
God.
point?
Oh, doctor, but then what about if I want pregnancies in the future? Because my husband always wanted, at least 4 kids.
Martha, I can totally understand your concern, and I can see that how worried and concerned you are. But because there is a situation where we cannot wait and watch, because this can be a life-threatening situation for you. So, so in such situation, we have to act in the best interest for you, and your surgery will be done by base experts, so we will try to save your womb. But if it is a situation where we cannot save it and we have to save you, then we might remove the womb. Am I clear so far, Martha?
Yes, yes, doctor. Okay. Let me, can I at least talk to my husband about it?
Yeah, sure, Martha. If you want, then I can also talk with your husband and explain him the situation, so he will understand your situation, what situation you are. So I will be arranging operation theater, and I will speak to my consultant and arrange your blood, arrange the
Hmm.
operation theater and the anesthesia, and I'll be speaking your husband also, so that
Okay.
you both can talk, and while I'll be arranging all things, everything for you. Am I clear so far?
Yes. Thank you.
So Martha, I'm here around in the emergency. If you ask any question while I'm arranging these things, you can call me again. Okay. Thank you for your time, Martha.
Thank you. All right. All right. You exceeded about 1 minute. Yeah.
Yeah, and it was also not good. Dr. Umar, I'm telling you my reflection.
Oh, why not good?
I don't know.
I want to
Thought
know
that
if you did the differential diagnosis based on the scan image, or would it have crossed your mind otherwise also?
I got only two differential diagnoses. One the hematoma and other was a scar rupture.
Right.
Other things were not coming in my mind.
Good. I mean, that's fair enough. Because everything,
Okay.
I mean, what you can rule out most of the things based on the initial assessment of the midwife itself, and
Hmm.
secondly, the very fact that you thought about the clot, okay, was
Hmm.
to be applauded actually. But tell me one
And
thing
I
in your
thought this is
experience.
emergency. Yes.
Yeah, go on, go on,
I
tell me.
thought that this is emergency situation, so I took targeted history. I cut short the smoking and uh,
Good,
I mean
good.
I don't know whether
Fantastic. I
okay,
really
okay.
appreciate that. But even then, yes, support also was, I feel a bit far-fetched right now. Uh, After discussing about the management options, etc., you could have, told about we will provide with support if you don't have any, or, that way. But
Hmm.
it's like in emergency situations, that would be something which is not required. Basic things are necessary. For instance, if she's on any medical condition that she have pregnancy related issues, which may point towards, bleeding, like preeclampsia, low platelet count, etc., or any bleeding disorder that you need to look at. Reservation for transfusion, you need to look at medical conditions, and you need to look at allergies and the personal or family history of clots. These are required from immediately making any sort of a safe management plan for her, and that's all you need to know in this station. I want to know, Manikam, are you here? Is
Yes, ma'am.
Manikam here? What do you feel about the presentation, given that it is a
It
extremely
was
new
so good,
station?
ma'am. But
Yeah.
I feel she should have simultaneously she should have resuscitated you. She
Mhm.
should start the resuscitation
Mhm.
measures
Mhm.
and call
Mhm.
for help. And
Okay.
it is my
Okay.
humble opinion, ma'am. Don't mistake me.
No, no,
Mm, they should have,
definitely not.
mm,
This is how basically we
simultaneously we
encourage.
have to give
Yeah.
oxygen and fluids and the RFT, LFT, everything to wide bore cannula to be
Correct.
inserted,
Correct.
catheterization if not already there, and
Correct.
then we have to do the measurement. A scribe can be allotted and everything to be. I mean,
Done.
the
For
we
basically,
have start.
PPH has
Hmm.
occurred, like
Eh,
somebody
yes,
is
ma'am.
almost on the
PPH
verge of
protocol. Yes, ma'am.
PPH
More or
protocol.
less
Yeah.
the same. Yes, ma'am. And we
Yeah.
have to
Yeah.
inform that the 4 units of blood to be cross-matched blood to be ready.
Mm.
We have to send
Mm.
the porter, the blood bank to be informed, and
Yeah.
the
Yeah.
anesthetist trainee for uh, along with he'll be helping us maintaining the
Mm.
ABC, and we have to keep her warm, and then the
Yes.
yes, ma'am.
All of that, warm
Then we
fluids,
have
etc.
to
Immediately warm fluids,
simultaneous.
and then
Mm, mm,
everything
mm.
simultaneously.
She's vomiting.
Yes.
Mm, yes,
Yeah,
ma'am.
Falak, don't worry about the assessment, because see, when you're doing a station for the first time, and it's almost like, I know you guys get worked up like as though you're performing in exams here. And if you have managed this much here, if you're able to keep your calm, then you will definitely do these things better in the exams, and that's what the whole exercise is meant for, so as to give you that sort of an experience. Okay, it's very easy as a bystander or as an onlooker for somebody to comment on how you have performed. So don't be discouraged with any sort of like feedback that you get here. Okay, Falak, you have done very well. All right.
Yes, Dr. Uma,
Yes,
I can
for
understand.
the first.
Actually, I was not thinking of the PPH because the interests are protected here. So I don't know whether we should talk about PPH here or not.
No, that's why I told you in the beginning, before starting the station, think as a clinician what you would do in the labor room for this woman. Like somebody who's having tachycardia or pallor. See, it's given to you. What does she have? She has pallor, she has tachycardia, she has a low BP. Obviously, she's lost blood somewhere. So you thought she's lost blood either via a vaginal hematoma or an intra-abdominal hematoma, which is a rupture, right? And more, then you wanted to confirm your diagnosis. So you wanted to do a per speculum, you wanted to do an ultrasound to look how much bleed and where to what extent the bleed is. Now, of course, this hematoma was also restricted into the broad ligament. This actually came from a clinical scenario I recently encountered. That's why I've like put it like this. So yes, there was a concealed sort of a rupture which was confined basically, but uh, ongoing bleeding will still occur if you don't take any step right immediately, and therefore you need to open her up and immediately control the bleeding, and simultaneously, as Dr. Manikam rightly pointed out, you need to start with resuscitative measures, call for all these people who are going to help you, call your consultant, okay, hematologist, anesthetist, then blood bank, okay, cross match the blood, take your midwife's help into putting that IV cannula, collecting the blood samples that you need. So you are going to say these things out loud in the station so that your examiner is marking you at the same time for leadership, okay, and delegation of tasks to the correct individuals, and whether you have grasped that this is in emergency hemorrhage situations, how are you going to manage the case? Okay. The rest of the thing is pretty obvious to all of us who have handled a hematoma situation, that we need to take to OT and we need to, take care of the bleeder, right? That everybody will be able to tell. But in the correct format, okay, it's necessary to do. Targeted history was a good point that you mentioned, that you needed to ask only specific things that will help you in managing this. I think the last line didn't show up. The HB phone back was 8.5 grams now. So you needed also to talk about blood transfusion, which you did any which ways without that investigation. So ideas, concerns, expectation in terms of what does she know and how is she feeling right now. They repeatedly, I was mentioning that I'm feeling just exhausted. I'm trying to feed the baby, but it's not happening. I'm feeling very tired. So just counsel her at that point, saying that yes, I'm going to come to this just with very few quick questions that I need to ask you. Ask about any pregnancy related issues over there during that point of time. Whether she has received counseling about the complications of VBAC, and does she know the complications of VBAC which may exist. Okay, that's also essential. Correct interpretation, again, I have included in information gathering. So when you realize that there is tachycardia, some sort of hypotension and pallor, and diagnose that there may be ongoing hemorrhaging, that is information which is written information provided to you, and you have made interpretation based on that. So in information gathering itself, okay. What quickly you need to ask about how she's feeling, faint, giddiness, pain, okay, any bleeding that she has noticed externally, because when you entered the station you didn't have anything else provided to you. So your ultrasound is not there, nothing is there, just the vitals are there, and you know that they are sinking. So visibly, how much have you bled? Asking this, like how many, after that 40-minute interval, how much did you bleed? Okay, that again will tell you if there was external, right, Falak? All right.
Yes, Dr. Uma.
Yeah. yeah, and whether she has managed to pass urine during this point of time. And how's the baby doing? That way you explored blood group, you explored BMI, allergies, any pregnancy complications you have asked for, previous obstetric history. What was the indication for that cesarean section and any complication at that time? And future obstetric expectation. This is something which didn't get, but I told you about it when you told me about the hysterectomy. Okay, why this is important is because you may propose a line of management where this is a possible outcome. Okay, this is a possible complication that you are going to inform the patient. It's always better to understand, all right, the supposed effect it's going to have on her expectations. Okay, Falak. So if you had asked this before and I told you like I wanted more kids in the future, and then your counseling about that OH obstetric hysterectomy part would have been slightly different. Like your sentence would have included, I understand that you wanted to have more pregnancies in the future, but sometimes I must tell you, I'm not trying to scare you, but it's not possible to salvage the womb, and we might have to take it out if the bleeders are not getting controlled of, or if it's, you know, ruptured very badly, okay, or the scar has given way, okay, to an extent which cannot be repaired, then to save your life, all right, and to stop the bleeding, we may have to do that. So, yes, reservation for transfusion, something you asked, medical, surgical on this. Communication again was good. It's only the main issues are around this area. Now, what I want to ask is, um, why were you telling her that the hematoma will result in, it'll go inside your bladder or cause ureteric injury? Is that the reason you want to evacuate the hematoma? Or what was your thought process behind saying that?
I was just wanting to tell her the name of solution. So it came in my mind.
Okay, now that you're not nervous,
I mean,
what do you think you
spontaneously,
should
yeah.
have actually told her
Yeah,
about it?
actually, she the risk of complication of that site collecting,
Falak, your voice is
she can be
breaking.
anemic. Sorry, Raghav. Uh, I was just saying her that maybe if the blood is collecting inside, that she can collapse or she can have multiple blood transfusions, and then if it is increasing in size, can put pressure on the ureter and then the kidneys.
Hmm, hmm.
So I was thinking of this point of view.
Uh, the bladder and the kidneys and all these issues are like long term. You wouldn't keep the hematoma in a woman who's like bleeding there, uh, because if it ongoingly already she's unstable, and if she continues to bleed, she's going to die before all those complications even that are conceivable, right? So that's not the reason you're trying to save her life because she's bleeding and she's not going to tolerate the bleeding. You can't allow it to, keep happening. That's the reason you're taking it. So you tell her the reality. When you speak vague things like that, it will do you some more harm in the station. Like speak very logical things that we have done this ultrasound now and we found that your hemoglobin is also low, and there is this shadow which is seen next to your womb, which looks like a blood clot. It is possible that as you already know, with a previous cesarean section, that there was a possibility of the womb or the scar giving way at the time of your delivery when we used the vacuum. Then because of that, it's possible that the bleeding is occurring ongoing inside your tummy, and we need to control that. Other lest what will happen is your blood pressure will keep dropping, and this is done as a life-saving measure. Okay, so vaginal hematoma is done. This initial part was being marked for when you advise investigation, when you advise the right investigations, right examination for the correct reason. So, how are you analyzing this particular event that has occurred? That is being marked in applied clinical knowledge. Okay. And then comes your emergency management of a postpartum hemorrhage. So, how do you need to say this thing to the role player that this is an emergency, Okay, so I will have to immediately simultaneously start, um, gathering help for you by communicating via. I'll just ask the midwife to speak to my consultant immediately about what's happened, and also alert the blood bank, hematologist, the scriber, and a porter to collect blood, etc. for you, and also inform the theater, inform the anesthetist. Okay, and another thing, I will ask the helping midwife to pass a wide bore IV cannula for you as well. Start immediately some warm fluids, okay, and send urgent investigations, which will include your renal function test, liver function test, clotting profile, okay, etc. All right, and also pass a catheter for you immediately. Okay, catheter. Don't forget the catheter. People in the rush forget about the catheter. So the management will be, unfortunately, we'll have to just do. There is no way of controlling this externally, so we'll have to operate, and we are going to have to try and control the bleeding which is occurring inside. Okay, but before that, we will arrange for the blood products to be there and start you on blood transfusions. And we will also keep monitoring till the final, we are able to take you inside the theater and fix this damage, which will be as soon as is possible. So in terms of intent of the procedure that you've explained to her, so we want to control the bleeding and also explain all the possible complications. So now you're at the stage of what consent you need to obtain from her before taking her to theater, right? So here you are going to say that initially we will try to evacuate the clot and to repair the womb if possible, and to control the bleeding if this is at all possible, and it will be our first intention. However, if it's not, then we may require to do a possible hysterectomy. I'm sorry to have to say, okay? Although I'm aware that you wanted more children in the future, more pregnancies in the future, it's possible that we have to do this to save your life. Okay. The reason you're doing all these things is later when if on table you have to do a obstetric hysterectomy, you can't come out and tell her that, this is what we have ended up doing and not having explained to her all of this. This all included in your patient safety. Okay. Possible in these complex cases where the anatomy is, in all in disarray, that there is possible bladder, ureter injury, chances are very high. There is also common complications like pain, infection, bleeding, and anesthesia related complications. Mostly it will be general anesthesia that will be given to you. Okay, post-operatively as well, we may have to monitor or shift you to the intensive care unit. Okay, you will have a longer stay than usual delivery patients have, and I will give you safe antibiotics and good painkillers. And after consulting with the hematologist, okay, we will consider for thromboprophylaxis, that is medications to prevent blood thinners, basically blood thinners. And I will also fill up an incident report and document all of this, what we have discussed right now, and we will support you ongoing with the breastfeeding and also provide you with counseling and support later. Okay, all right. So if the womb is saved, then you have to talk about like future implications. As you mentioned, this is just because it's an exam station. In real life, you wouldn't do this, but because it's an exam, there are certain things that are done slightly differently. For instance, she wanted more kids, so you have to save the womb is saved. However, the next time you cannot have a vaginal, it's not recommended to have a vaginal delivery. Once a rupture has occurred, it's contraindicated in the future, if you know. Okay, and if a need then of womb removal is necessary, then we always have the options of surrogacy or adoption. So you can be a biological mom by using your egg and partner's sperm into a surrogate mom, or there is also the option of adoption. So don't be disheartened at all. And then take her like start with all of these things. All right. Yeah. Dr. Falak, well done. Well done. This line of thinking is correct, and approach
Okay,
to the
thank you, Dr.
station
Uma.
was correct. So yeah, but do you
Now
see that
I,
patient safety is getting compromised?
yes.
So how patient safety gets compromised when you perform offhand like
Hmm.
this, right? If you don't say things that you know, these are things that you would do
Yes,
in these stations.
yes,
So just not saying them in the correct atmosphere during the exam. That's the thing that happens most of the times. Okay. So,
yes.
okay, good one. All right. Any questions on this, Dr. Manikam or anybody else listening? Divya, Dr. Usha, can see some. Okay.
To give this FFP and all may be needed, ma'am. No, ma'am.
No, initially you have to talk. Yes, you will say blood or blood products
Hmm.
when you are
Okay.
talking.
Hmm.
Yeah. It will all depend on how many transfusions that you gave and what all ended up happening. But you're talking in an SPT, no? You're not saying
Ma'am.
it in a structured
Oh,
discussion. You'll say blood and
hmm.
blood products may be given.
Okay,
That
ma'am. Incident reporting and all, ma'am. Okay, ma'am.
statics is there.
Yes, ma'am.
Hmm.
Statics.
Okay, but obviously you don't have to speak longer things like when there is clinical governance highlighting stations where somebody is an angry patient and you are talking about ethics in more detail, like what we will do this, and
Okay.
a thorough, transparent evaluation will be done and anything will be communicated to you. That you don't have to. You'll say that I will also do an incident report and keep it at that. You don't have to like uh, do that in all the stations. This is not an angry patient. This is somebody who has had a complication and a known complication for VBAC. Hmm? So here the objective was to tell her that this is what has happened. Firstly, tell her what are the possibilities you're thinking. Once you've been given the investigations, your objective is to tell her how we manage this case. Now, the same thing I could have put to you as a structured discussion wherein there is the scenario given. There are some meow chart which has been given, which is showing tachycardia and this. And then the examiner asks you, what are your differential diagnoses? What are you thinking right now? What more would you want to know in this case? Then subsequently, it will be okay, these are the reports provided to you. How will you manage this case? So same thing can be asked in that format, same fashion, same sort of answer. Okay, just that you're talking to a lay person right now. You're talking to a patient.